Thank you for joining the AVNeo Roundtable. This roundtable was originally broadcast live on March 14th, 2024. AVNeo Roundtables are intended for experienced AVNeo surgeons to discuss key topics related to the AVNeo procedure. In today's roundtable, Dr. Massimo Porqueddu will start the discussion about using a mini sternotomy for the AVNeo procedure. Patients are requesting the approach, but what does a panel of expert cardiac surgeons say? Stay tuned to learn more. Now, I'd like to introduce Dr. Massimo Porqueddu, who started his AVNeo program in June 2022 following a proctor visit from Dr. Marcus Crane.
And the second day, I was able to do the first case on AVNeo with his assistance. And after this experience, successful experience, I realized I had the awareness that this procedure can be done independently in our center. So we start to work to build the program. And the first goal was spreading the knowledge of AVNeo in our hospital because nobody knew anything about these procedures. We didn't have any special issues with the administration. Everybody knows that this procedure is very cost effective. Our cardiology were deeply involved in order to define selection criteria and enroll patients. And also echographists were trained about post-operative imaging, evaluation of the new valve in terms of mobility of the leaflet, gradients, quotation lengths, and so on. Then we selected a dedicated OR team who was trained about all the steps of the procedure, and also a OR nurse team was trained in order to be independent in the treatment of the pericardium after harvesting. So I have to say that now after 20 cases, the procedure is being considered a routine in our hospital and everybody knows about it. Just a few words about the patient selection. The first 5 patients were patients with very low Euro score, low comorbidities, younger than 60 years old, and with symmetric tricuspid aortic valve. After that, we have to deal with some bicuspid, but type 0 bicuspid valve. And luckily, we didn't have to move any commissure. As I mentioned before, we were lucky because we were able to respect the rules that every leaflet should be or equal or no larger than one size. And so in these cases, we just moved the commissure at the level of the raphe in order to move, we changed the height of this commissure in order to have all the 3 commissure at the same height. Then after that, we did some cases with small annulus and we obtained good results, but we noticed that this operation is a little bit more demanding because the space of work is a little bit smaller. Then we start to perform some combined cases with, we did mitral, repair, couch. So we were more confident. Also, we were able to decrease progressively the cross-clamp time. And one of the most complicated cases we did, and Murad was with us in Jeddah during that time, we did a case of quadricuspid valve. Very uncommon, but we were able to move just 1 commissure and not create 2 commissure. Basically, not so easy to explain to you without the slides, but one leaflet of the 4 was bigger than the other one, and so we were able to keep 2 commissure and to create a new one. So basically, we were following the same rules followed for the bicuspid valve. This criteria was explained very well by Professor Marcus Crane during one, I think, webinar last year or 2 years ago. Our results were good, even if we know that good result, but the patient were, especially the first 10 patients were, there was a good selection of this patient. And the length of stay was less than 1 week. We didn't have to convert to standard AVR any patients, and hemodynamics was good. We didn't have even no mild aortic regurgitation, only trivial or trace with a good gradient and mobility of the leaflet. And then at the end, I would mention what you asked about this minimally invasive approach. We did 2 cases recently, 2 months ago. And basically, the approach is a classic mini sternotomy, J mini sternotomy, going towards the fourth right intercostal space that we generally use in routine AVR. Of course, the new step is the harvesting of the pericardium. So in the first case, we did the J mini sternotomy, and we opened the pericardium at the level of the ascending aorta, and then it's relatively easy going to the right side, towards the right atrium, towards the right phrenic nerve. At this stage, we cannulated the aorta and the right atrium. We went on pump, and the heart was completely drained. The lungs were down. In this condition, it was possible to harvest the pericardium going towards the diaphragm, and also the most difficult part on the left side. And so we were able to harvest the classic 7x8 pericardium and obtain the 3 leaflets. And then we did another case. In this case, it was possible to harvest the pericardium without going on pump. We start from the ascending aorta, going towards the right side, and then step by step, retracting the hemisternum, and with some traction stitches, was possible to take the same area of pericardium. But I have to say that these 2 patients were selected patients, not obese patients, and so we cannot say that this technique, this procedure can be extended to all patients. We just at the beginning of the experience, but we show that it's possible in selected patients to perform this procedure even without thoracoscopy, because there are experience in the past of some team that did the mini Ozaki or mini AVNeo with with the thoracoscope.
Right.
So I think that's all. I think this is a general overview and of our experience, and
so
I think that's it.
a couple questions. So you mentioned about doing the bicuspid. You said a type 0, but I think was it you did a type 0 or you did type 2?
No,
Bicuspid.
no, I did only type 1. Type
1.
0, no. Type 1, yes.
Okay.
And I said in the valve we did, the 3 leaflets were relatively symmetric, and so we were able to not move the commissure, because there was only one size of difference between the commissure of the 3 leaflets, and the only thing we did to move a little bit the height of the. I think the one done with Professor Crane was one of that. It was the first one. It was bicuspid. We move a little bit to the conch. I remember that. Yes.
Yeah, this is something that we're trying to address, because obviously, when we start talking about the non-elderly patient, so under 60, we're going to see a high percentage of bicuspid valves. So I think there's some work that we need to do as a company to try to develop a training to make sure people are more confident and more comfortable with moving from a tricuspid valve to a bicuspid valve. So that's one of the things I want to develop over the next year, is a program that can kind of advanced training, I'll call it, where people that have some experience but want or need to get more comfortable with doing a bicuspid conversion to tricuspidization. So I think there's definitely some work we can do there. My second question is about the need to do a mini sternotomy, and talk to us a little bit about why you want to do a mini sternotomy versus doing a full sternotomy. What's the rationale? Because it seems to me it seems like it's adding some complexity to the procedure. So I just wanted to better understand your perspective.
First of all, I have to say that we are using mini sternotomy in most of a regular AVR. So all the team has experience in dealing with the AVR with this kind of approach. So this is very important. I don't think the exposure of the aortic valve is so different in the mini sternotomy. Usually the exposure is very good, and so basically, one time you see the aortic valve, I think all the steps of the AVNeo are exactly the same. The problem is the preparation and, of course, the harvesting of the pericardium. And as I told you, we selected the cases that this patient were not obese, and also we did a CT scan before the operation in order to have an idea how far is the aortic valve from the sternum, because this makes the operation more or less complex. But basically, our goal in the moment is not to do all cases in mini sternotomy. We are focusing to build a symmetric valve, a well-working valve, and in some selected cases, we will, try to extend our experience with mini sternotomy. About the advantages of mini sternotomy, there are no randomized trials at the moment, and there are some papers, studies which are contradicting, but most of the papers show that the advantage is less bleeding, less use of blood products, a shorter stay, length of stay in the hospital, and of course the aesthetic issue that. But these are the main advantages, and especially the stability of the sternum, also in the radiomediastinitis, is less in patients operated on with mini sternotomy. But of course, after 2 cases, we cannot say anything. We just say that in selected cases, it's possible to do it even without thoracoscopy. That's what we can say.
Yeah. Okay. Hello, Dr. Albertini.
Hello, sorry for the delay, but I just finished in art.
Okay. Hello, welcome. Thank you. So Dr. Crane, have you done or thought about doing a mini sternotomy for AVNeo?
So first of all, I would like to say that's a great pleasure to meet all these people again and again, which I have had the fortune to meet all over the world. And it's great to see that you train somebody, he's picking up and going on moving forward, doing his own procedures and doing his own procedures successfully. That's really, really an honor. Yeah, mini sternotomy. I've thought a lot about that because patients are asking for it. So if you go to the patient and try to inform him about AVNeo or biological AVR or mechanical AVR, you every time have to say that if you are going for AVNeo, most likely you will have a full sternotomy. If you are going for AVR, most likely you will have a mini sternotomy. And this 2 centimeter, 5 centimeter of the scar is very important for the patient. I don't know if there's really a big advantage between full sternotomy and mini sternotomy. Some report less pain, some are easier to mobilize after surgery, but it's not a huge advantage. But yes, patients are asking for that. That's why you think a lot about the fact if it is possible. I like to hear that now there's a second surgeon, up to my knowledge, who did it, minimal invasive. There was a previous experience in Vietnam, I guess.
Right.
Same approach. That's also nice to hear that different people on different parts of the planet are thinking about that and come to the same conclusion. So open the chest, go on pump, harvest the rest of the pericardium on pump if you are not able to get it safely harvested without pump. So it's meeting at the same point. If I would be asked how the optimal patient looks for that, I think they are different. And there are some patients who are really difficult to operate on in the mini sternotomy. These are the patients where the level of the aortic valve is very much to the abdominal part, so to the lower body, because you can reach them only with a lot of difficult exposure part, and especially exposure of the wide coronae is difficult in the patient. But there are, of course, patients who, with a mini sternotomy, the valve exposure is basically the same like in a full stent. So the question will be in the future, if you want to do that for AVNeo, how to identify these patients. Perhaps the CT can get you some information how approachable this patient will be through a mini sternotomy. Usually, but this is just not really shown by numbers, but my gut feeling, that women are often easier to operate on with a mini sternotomy compared to men, because in men the level of the valve is a little bit lower, but perhaps other people have different experiences. So these are my thoughts.
Okay, great. Dr. Albertini, how about you? Any thoughts on doing a mini sternotomy for AVNeo?
So, I mean, one of the problems that we had when we started with AVNeo is that we were doing 100% of the aortic valve procedure in minimal invasive, mini sternotomy or mini thoracotomy. So it was quite difficult for us to justify full sternotomy for an aortic valve procedure. So actually, we have done only full sternotomy AVNeo. We are trying to plan how to do it in minimal invasive, of course. I agree with Marcus Crane that we can use it and also with Dr. Porqueddu that we have to do this, to consider minimal invasive approach only in selected patients. I have mainly two concerns about minimal invasive approach for AVNeo. One is the exposure of the aortic valve, an ideal and a good exposure of the aortic valve, and so we have to consider patients with not so deep chest, and as Marcus was saying, not cases in which the aortic valve is very dislocated into the chest, and the other concern is about bleeding. I mean that the minimal invasive approach, by harvesting the pericardium, you cannot control very well the hemostasis of the pericardium that we cut. So these are the two concerns that I have for a minimally invasive approach. Probably we will move to a thoracoscopic harvesting of the pericardium. Because in this way we can control very well all the cutting of the pericardium. So we can also control the bleeding in case of bleeding from the pericardium that is harvested. So these are my considerations about minimally invasive approach. Theoretically, it can be possible also to do in mini thoracotomy also. We do a lot of mini thoracotomy AVRs.
Okay. How about Dr. Bakutashvili? Sorry about that. Have you done any of the anything other than a full sternotomy?
Good evening, everybody. Again, I did not do any AVNeo with partial sternotomy. And I am agree with Dr. Albertini that it is risks for bleeding after harvesting of the pericardium. And another my contraindication, let's say, it's that our colleague told that he is harvesting pericardium on the extracorporal machine. So it means that we should do longer machine time with harvesting of the pericardium, and we know that without this AVNeo procedure is at least 2 times longer than regular AVNeo aortic valve replacement. So we especially in West European countries, in older patients, we are doing TAV procedures. So most of my patients are 70 years or older. So in older population, we are. It means that I should prolong extracorporal time, which could be in some patients not so safe. So in this moment, I don't consider that it could be a good idea for patients and for method too, because it could make compromission of the AVNeo procedure for other doctors who'd like to start, or for patients also, because now every patient look for statistical. So when you explain that what to do, biological valve or AVNeo, you should we should present them results of the these 2 methods. So in nearest future, I don't plan to do mini sternotomy. Only the maybe way to harvest the pericardium, it is endoscopic endothoracoscopic method, which could be much safer, of course.
So, Dr. Porqueddu, any comment?
In my short experience, I said just 2 cases. I told you they were very selected cases. We had experience, long experience in mini sternotomy, so we knew already that the exposure of the aortic valve would be ideal. And honestly speaking, these 2 cases, to take the pericardium, maybe it took 5 minutes more pump in the first case, and the second case was ideal. Of course, about the bleeding of the margin of the pericardium is a good concern. I think that's the reason why when we were on cross clamp, we revised. So in an ideal condition with the heart completely drained, we revise before going off pump all the margin and try to optimize the hemostasis. I agree that this can be a concern. We should be careful to do a good hemostasis, yes.
Okay. Dr. Krane, you have your hand up.
Yes, because this was a very important point which was made, Basiat, that it depends perhaps on the country where you are working. So I'm sure in Italy and in Germany, we are competing with this mini sternotomy in young patients. And cardiologists are referring patients for mini sternotomy because they think it's very important to do that. And if you change their plans, A, to a different procedure, B, to a full sternotomy, could be that it was the last time that you get a referral on this kind. So you have to explain them why you are doing what. That's why I think if we want to compete in the future with this procedure in the isolated aortic valve world, in countries also like Germany, Italy, and so on, then it is a good thing to try to pave a way for mini sternotomy and AVNeo. I just don't have any experience yet, but I totally agree that we have to think about that we have to find a good strategy for that, how to do it. And perhaps it depends a little bit on which kind of patients you are treating and to whom you are competing.
Yeah. I think it's a good point. Dr. Albertini?
I fully agree with Marcus. I mean, so probably it is technically possible, but we must warrant the safety of the procedure. There are many advantages in doing a mini sternotomy or mini thoracotomy comparing to full sternotomy. So we were also thinking, just considering the technical possibility to harvest the pericardium, to do it on pump. I mean, by deflating the lungs and working with the empty heart. But probably I will feel more safe by harvesting through thoracoscopy. I mean, doing a many mitral valve surgery in thoracoscopy, I think that probably this is the safest way. I mean, you can check the pericardium, the harvesting of the pericardium with direct vision. I mean, with the thoracoscope. So probably we will use this technique for harvesting the pericardium.
Okay. Dr. Tash, you have your hand up. Hello.
Yeah, hello. Hi. First of all, I would like to thank you, Damon and Murad, for this kind invite to this roundtable. I'm still learning about this procedure. I did a couple of cases, but I have a long way to go, and all my cases that I'm going to start at the PSCC will be full sternotomy for the first 10 cases. But we are starting the robotic program also at the PSCC, and I think the capabilities that I saw from dealing with the robot, I think harvesting the pericardium with using the robot is probably going to be, I know that this is a very heavy burden financially on many centers to have a robot. But for the centers that do have this technology, I would think that harvesting the pericardium, and I would like to elicit the opinions of the leaders in this procedure. Harvesting the pericardium using the robot would make a lot of sense. It would take much less time than harvesting endoscopically or using the endoscope to harvest with minimally invasive, and more precision. This is one point. The other point is that there is a question about who are we competing with, and I think we are competing with the SAVR, the straightforward surgical aortic valve replacement, and we are competing also with the TAVR. And in order to continue competing, we need to shift to more and more minimally invasive. And minimally invasive is not just a smaller wound, but a shorter pump run, a shorter cross clamp, and a better outcome. So I believe that we could achieve all that using the new technology with the assist with the robot. And the more and more cases we do, we will be able to deal with the different aortic pathologies, severely calcified, smaller aortic roots, bicuspid, type 0, type 1. And I congratulate Massimo for he did all the types. He did the trileaflet, the bileaflet, and the quadrileaflet. So I'm really proud of having Dr. Massimo here in Saudi Arabia and having Saudi Arabia on the map for this important procedure. And thank you very much again for inviting me, and looking forward to really seeing the experts here in Saudi helping us and teaching us and training us on more and doing more and more of these cases with precision and great outcome. Thank you.
Thank you, Dr. Tash. So, Dr. Khana, you obviously had some experience with the robot when you were at Yale. What's your thought on that?
This will be a challenge.
So we are
Okay.
starting.
It's already very challenging to go for aortic valve replacement using the robot. I have to say. So using the robot for AVNeo.
But I meant as an assist just for the pericardial harvest.
Oh,
so we do a mini
harvesting.
sternotomy, but a very small, limited mini sternotomy. I noticed that Dr. Massimo, he went to the fourth intercostal space, but we could do a mini baryotomy, in fact, and do an aortic valve replacement. So a very limited mini sternotomy, and the robot is there to assist in the pericardial harvest.
Okay.
What do you think of that idea?
Yeah, I got you. That depends a little bit because you need your space for the working port. So you have to introduce the working port. The working port has to go through the chest, and then you need some space to work with that, to navigate that. This is what means very easy. This is already very complicated for the mitral valve because you're coming into a lot of conflict with the arms when they are moving. So if you are in the small space of the mediastinum, without deflating a lung and having a lot of space for the robotic arms, it could be adding a lot of complexity, which could be avoided if you just use endoscopic instruments. And as we have heard today already, the experience that in some cases it's just easy to harvest the pericardium without going on pump. And perhaps going on pump for 5 minutes, 10 minutes, harvesting endoscopically the rest of the pericardium, go off pump again, what should be possible at that point. Fix your pericardium, do everything else, go on pump again, and dissect the aortic valve. It's perhaps much easier. And I have to say, I couldn't justify in my hospital. Perhaps that's possible for you, but for me, it's not possible to invest another 5,000 just using the robot for harvesting the pericardium. So unfortunately, the German health system is not providing that.
Okay, we have extra money for robotic procedures, so we can justify.
Okay, thank you. Dr. Leo, you have a hand up?
Yes, just a question to people that have performed many of these procedures. But in my opinion, apart from the technique that you are going to use to harvest the pericardium in a minimal invasive, a mini thoracotomy, mini sternotomy approach, especially in some circumstances and different difficult anatomies, the pericardium is used to retract the heart to have a good visualization of the aortic valve. So if you harvest the pericardium as in a AVNeo procedure, do you think that this point could be a difficult part of the operation for the AV procedure, because you have not the support of the pericardium to retract the heart? So is it possible for you to have some probably CT scan measurement that you can use to select the patient, such as distance from the sternum, angle of the aortic valve, and so on?
Yeah. Dr. Porqueddu, go ahead.
Just from the limited experience I have, I would say that the case we had done, the harvesting of the pericardium was easier than expected and honestly relatively safe. Because, in mini sternotomy, usually you see very well the pericardium around the aorta, so you can start from there. And then it's very easy to go on the right side, around the atrium, okay? The problem is to reach the diaphragm and to do the left side. In our case that I said are selected, you start with some, you raise the point. Of course, you have to put traction on the pericardium to do mini sternotomy, but progressively, taking the pericardium, we put stitches on the pericardium left. So at the end, you will have the same stitches like in classic mini sternotomy. And this stitch can, of course, help you to expose the aortic valve. And I have to tell you that in these selected cases, also to take the diaphragmatic area and the left side area, not just matter of a retraction of the hemisternotomy with some retractor and pulling with some traction stitch. So honestly, it was not so difficult. But we have to say that intercostal space was the fourth and not the third, because this will make a big difference. And also the patient were not obese, as I said. And so in these cases, I think honestly, it's not so difficult to proceed. The problem will be in obese patient where really will be very difficult to see the diaphragm. So I feel in this patient, even draining completely the heart, honestly, it will be not so easy. But in the not obese patient, I think it's not a big deal to take safely the pericardium.
Interesting. Okay. Go ahead, Dr. Albertini.
Yes, I have a question. What do you think of using, for instance, the ultra excision for harvesting the pericardium? Massimo.
Sorry, I didn't hear the question. Can you repeat?
What do you think? Because you are harvesting the pericardium in full anticoagulation, right?
Yes.
What do you think of using the ultra excision?
Yeah, this could be a good idea, honestly. We used the coagulator with some extension, but we didn't use the ultrasound. You mean the harmonic scalpel, right?
Yes.
Could be okay. You mean to facilitate the hemostasis?
Exactly. We have a safer hemostasis.
Okay, we didn't think about that, but I know some experience to take a pericardium with harmonic scalpel, in full sternotomy. We didn't try with full sternotomy to do this. It could be an idea. As I said, we review in both cases very well the hemostasis when we were on cross clamp, and so you can, with the pericardial stitch, expose all the edges and be sure that everything is dry. But this could be a good idea.
You can check also easily at the end of the procedure after giving the protamine.
Honestly, in one case, in the first case we did would have been the left side would be not so easy to see, honestly, because it will be relatively far. So it depends on the anatomy of the patient. I think the left side probably will be difficult to see this area of the pericardium. Yeah. The diaphragmatic area and the right side you will see well, but the left side is the most difficult to see.
Okay. So a couple of times people have mentioned that to do or to recommend doing the mini sternotomy, we need to have some better understanding of the anatomy of the particular patient. So just out of curiosity, are you doing CT scan on every patient before you're doing the aortic valve replacement?
Yeah.
In the case, in one patient we did, there was a CT scan. In the other one, no, but it was a very thin patient, so we didn't do it. I can tell you one thing, just to make some historical remark, because I was at that time, basically this J mini sternotomy was introduced in the late 90s. okay, in Cleveland Clinic. And that time I was a fellow in Cleveland Clinic. I was working with Dr. Cosgrove. And so I remember at that time, that's the reason why maybe I was so willing to do it, because I was preparing his case and we were doing like 3 cases per day. This was the time before mini thoracotomy for mitral. At that time, the mitral was done with J mini sternotomy, but the intercostal space was not on the right side, was the 4th on the left. So I remember that I seen and assisted like 100 cases in few months. And I remember that for the aortic valve specifically, the CT scan was not done. So there was a really a routine way, every step was codified. I think it's a matter of experience. But the problems are the obese patient, very obese patient. In this case, that maybe this patient would benefit more from mini sternotomy, but are the patient, we don't like to do it because honestly, this patient, the exposure, it would be difficult, whatever you do from this approach. But I think depends if you do every day, if you do a lot of procedures, because also to put a pacemaker wise at the end would be difficult. To put a drain will be difficult. As you know, you do every day, so it needs to be done on pump. So every small steps is a little bit more complex. So I think my idea is to try to do some selected cases. We are at the initial stage. I don't have the experience of Professor Crane or Dr. Albertini. So I think in our center, we will do selected cases in mini sternotomy. We try to build our experience, but our major goal is to keep going and get more and more experience to build a good aortic valve. This, I think, is our major goal.
Yeah, no, I think it's a great idea. And as Dr. Crane mentioned earlier, the patients are asking for this, right? I've heard this same kind of question or conversation all over the world, that people introducing the AVNeo procedure and asking about are people doing mini sternotomies to do the procedure? So I think there's some relevance and some importance for us as a group to kind of move this forward. So I think one of the things that, if we can, Dr. Porqueddu, is to try to as you're evaluating each patient, let's try to keep really good notes and scans and be able to then write out some kind of justification or qualification for which kind of patient is good, because you may find that you do the CT scan and everything seems to be appropriate for doing the mini sternotomy, and then you start to do it and you find, oh, maybe this patient wasn't the ideal patient. So if we can start to try to create some selection criteria, maybe it's using the CT scan in addition to some other measurements, then I think we can start to have some other people starting to use the technique as well, as long as we have some kind of basis of criteria. What do you think, Dr. Albertini?
I agree. I mean, we had to consider I mean, all the aspects that you said. So I mean, we are, as I said, we were doing 100% of the AVR in minimal invasive fashion. I mean, I think there is the possibility to do in minimal invasive an AVNeo probably easily. But we have to consider the safest way to do it. To consider the tools that we must use, that are probably not exactly the same tools that we are using, the same instruments that we are using for minimally invasive AVR. I think that probably a thoracoscope can help a lot in this way. Even by harvesting the pericardium through a thoracoscopic approach, thoracoscopic approach, but also in mini sternotomy, we can use also the thoracoscope to check under the sternum, the pericardium, for instance. By using the harmonic scalpel, probably we can do a safer hemostasis, a better hemostasis. So there are many aspects that we have to consider for a minimal invasive approach.
So open to any thoughts on that. So what do you think the best way to kind of move this evaluation forward is?
We are a center at high volume of minimal invasive, but for mitral and for aortic. So I have more than 3,000 procedures that I've done in minimal invasive.
Yep.
And I still have concerns in doing an AVNeo in minimal invasive way. I'm thinking about it every day. How to do it, but I don't want to compromise the results, and I want to do a safe procedure.
Right. Dr. Crani, what do you think in terms of could we move this idea forward somehow? Do we need to do a study? Do we need to do what do you think we should?
I think we must find out at least a standardization.
Yeah, I think this is very important. Somebody has to take the lead on this and try to standardize that.
Yep.
And the person who is doing that, and of course it could be you, should document that very well and talk about that, doing webinars, doing videos, doing descriptions of that, publishing tips and tricks if you do that, how you do that, to inform others that they can also start with that. And the wonderful thing is, if you have at Cleveland already collected a huge experience on the access, then most likely you are in a very, very good position to do so. And I would love to invite you to Munich, and you just give it back to me and show me how to do that in minimal invasive fashion. So that's what I was thinking about, that somebody has to start it. Unfortunately, I don't remember the name of the surgeon in Vietnam, but he never educated other people on that. So he did it, he published, and that's it. But there was no education of other people how to do that. And this would be wonderful if somebody would stand up, say, okay, this is my experience. I did whatever, 20, 30, 40, 50 cases. Here's my video material to that. Here is my drawings to that. Here's my tips and tricks. And if you want, I can join and do it together with you. And of course, Damon, AVNeo, and Xana Media is in charge to provide this knowledge to others.
Yeah, no, absolutely. Murad, do you have a hand up?
Yes, I have just a question. Is there any? So, how many patients, for example, when you propose AVNeo, they could say no because it's full sternotomy, let's say, or how many patients they say no? First of all, if we are proposing AVNeo.
Can I answer?
Yeah, go ahead, Albert.
So I have no patient that were refusing the AVNeo because of full sternotomy, but many patients arrived to me expecting a minimal invasive procedure. I have to explain that actually it's not possible to do it. I mean, not possible. It's not possible. It's not true. But in my hands, it's not possible. I mean, I have no experience in minimal invasive AVNeo. But many patients are expecting a minimal invasive procedure. They arrive to me saying that is it a minimal invasive procedure? No, sir. It is not.
Dr. Kane, how about you? Do you have any idea what percentage of your potential AVNeo cases that's refused because of full sternotomy?
None. So to be honest, as a surgeon, you can convince your patient of advantages and disadvantages.
Okay.
That doesn't mean that you should go for the full package of advantages.
Right.
You know what I mean? So the best way to do that, and most likely everybody in this group agrees to that, if there's a way to do it safely, in time, with good results, best way to do it is minimal invasive. So that's why I think it's not a question about are we losing patients to whom we are offering AVNeo just because of full sternotomy. The question is there a way to offer the full package to the patient?
Exactly.
I guess is the question.
Yep.
And on this way, we have to work on it.
Okay, great. No, I think that's.
And nowadays, I have to say, most of the patients who are 60 come with the idea to get a TAVR, to be honest.
And I think that's kind of to back to.
And then you are talking about the full sternotomy, so it would be much easier to talk about the mini sternotomy.
That's exactly right, and I think Dr. Tash was very right on with his comment that we are competing a little bit against TAVR, and if the question is catheter based intervention versus full sternotomy, then patients are clearly going to the least invasive way, which is the TAVR, right? So if we could offer the minimal sternotomy, maybe then some of those patients would benefit from getting the AVNeo rather than getting a TAVR, especially in the younger patients. So okay, so Dr. Porqueddu, thank you very much for your summary of your experience, and I think you have been selected to kind of lead this effort for advancing the minimally invasive. So I will work together with you, and we can work with Dr. Crane and Dr. Albertini and others to I will also try to get with Dr. Din, who is from Vietnam. He's the one who's done, I think probably like 100 cases using a right thoracotomy and then a mini sternotomy approach. And I will try to get connected with him and connect with Dr. Porqueddu to try to establish some guidelines for that as we go forward. But I think it's important for us to try to move this forward. So I look forward to continuing to get the support from Dr. Porqueddu. So thank you very much, everyone. We're up against the 1 hour. I want to respect your time. So thank you very much for attending. And probably in June, we'll have another one. The next one, I want to come back to this question about the anticoagulation. So I want to come back to that on the next meeting. So I found the results from the survey that Dr. Albertini was mentioning in the last roundtable. So I think we can bring that up as a topic of conversation. But thank you very much for your time. Have a good rest of your evening and your day, and we'll talk to you very soon. Thank you for joining.